Hey there, welcome to Chapter 4. This is your lecture on interactions that you will have in the field as a CCP. So we're going to jump right on in. All right, so our interactions, these are the heart of patient care-centered care. So the exchanges that occur between the community paramedic and the patient's family, their caregivers, other providers and organizations delivering healthcare services, resources available in the local community, and insers of all types, pretty much. So we're preparing for the first patient encounter before we have the patient encounter. So we have communication with other healthcare providers. That is absolutely key, whether it's directly or whether it's by the patient's medical records that we've reviewed beforehand, especially with the referring hospital, the medical director, primary care physician, and specialist involved with the patient's care. We want to get different EKGs, lab test values, per local protocol, of course, and any baseline vitals that we may be able to obtain beforehand. We want to know what their normal baseline for their blood pressure, heart rate, respiratory rate, O2, if they even use oxygen at home or not, know what their end tidal is, their normal weight, temperature. And after we collect this data, consult with the medical director to ensure that these baseline measurements do not signal the presence of an acute issue or something deeper going on. So our enrollment visit. So let's talk a little bit about what that enrollment visit is, because there are several different types of visits that you're going to have as a community paramedic. So this is generally the first or the second encounter the community paramedic is going to have with a patient. This visit is the community paramedic's chance to make a good first impression. You really want to build rapport. It's hard if you start the appointment on a bad foot. It's hard to pick it back up and change it. So do your best to set a good standard on that first meeting. So during the visit, the community paramedic is going to discuss the aspects of the local community paramedic program. Let them know what your program is about. Also going to talk about the initial patient's goal per the plan of care. What are their goals? You're also going to go through their overall understanding of the roles and the responsibilities in our program participation and how key it is that they stay involved with the program. You'll go through introductions as well as explanations. During the enrollment visit, the community paramedic and the patient are also going to discuss a visit schedule. So pull out a calendar, sit down with them, and put stuff in writing right there, so that way they are committed. A projected end date for achieving these goals. Once again, you want to have definables for little goals to help them meet their big goals at the end. You also want to try to establish an endpoint. That's going to help motivate both the patient as well as you to reach the goal of the plan of care within a certain time frame. Deadlines can be our best friend. The patient may receive a short card or pamphlet as well that you have with them that can describe the goals of the community paramedicine program, can define the visit schedule, can give them contact information and what the best ways are to reach you. Maybe a website. So there also should be a non-emergency telephone number where they can reach out and call someone if needs be. For our patient assessment, we do have to do a complete patient assessment. This should include a physical examination, and this is performed during that enrollment visit. If the visit takes place at the patient's home, a complete physical examination will be conducted there. If the patient is in the hospital, that may delay that physical examination until that intake visit, but primarily during that first visit, that enrollment visit, is when we do that assessment. You want to do a medication inventory as well. So this should be obtained during that enrollment visit too. So when setting up the appointment for that enrollment visit, you're going to ask them about all the medications available, what medications they take that are prescribed, those over-the-counter meds, herbal supplements as well do count. So you should also access their medical records. That way you could obtain an accurate and up-to-date medication list. If the enrollment visit is in a patient's hospital room, verify the medication inventory during that first home visit. Ideally, the medication inventory would be recorded electronically if at all possible, so in a charting system. For ending our visit, at the end of the visit, ensure that the documentation of the visit is complete as well as thorough. Follow your local protocols whenever you are submitting it and documenting it for review. You will have different standards depending on where you are working. Next, we're going to talk about that intake visit. So usually it is the second visit that you make. So the second visit is the intake visit. It focuses on identifying all social medical aspects that relate to the patient. It also is going to talk about barriers to good health or care. This visit includes a full patient assessment, including a physical examination if one could not be performed during that initial enrollment visit. This is the time that you would do it now. Some community paramedicine programs combine the enrollment visit and the intake visit into one. That will be up to your agency and their discretion as to how you roll that out. The intake process includes all aspects of the patient's livelihood and assesses how well he or she is able to perform the activities of daily living, your ADLs. A standard checklist developed by the Community Paramedic Program is highly recommended. So if you don't have that yet, that might be one to add to the to-do list down the line. For a patient assessment, a complete patient assessment, including a full physical examination, should be performed during each visit. That assessment will include weight measurements, point of care lab tests for specific conditions. That once again is protocol permitting as well. So make sure you are following your particular protocols that are set by your state and your agency. The patient needs assessment is another one that we also need to do with them. This is the patient's social needs that may be evaluated through that needs assessment. This is a tool that takes into consideration factors such as the patient's health history, their current living environment, what social networks they have in place. A thorough patient needs assessment provides the patient information that the community paramedic requires to help to determine all of the patient needs that they have. Follow-up or scheduled home visits, they look a little bit different. So our follow-up visits are scheduled non-emergency visits that follow the enrollment and intake visits and focus on monitoring and managing of the patient. So managing and monitoring. Each follow-up should include this. We're going to do another full patient assessment, goal and plan of the care of review and management and how they are meeting those benchmarks, disease-specific education, ensuring understanding and compliance with the plan of care that you have put together. You're going to review of the visit and confirmation of the next visit scheduled date. So go back through, give them the chance to talk about the visit and let them know how, or let them tell you how they are feeling about the process that they are making or the progress. You also need full detailed documentation. This is supplied to the medical director and the members of our healthcare team, however your local protocol has dictated that rolls out. During our follow-up visits, it is important to help these patients understand and develop a communication process with their long-term providers. So that would be their primary care physicians, any specialists that they're seeing, case managers, social services. So one way to facilitate patient communication with his or her provider is to provide a patient binder. So putting together a binder that's full of educational materials for them. That can ensure the continuity of care and avoid duplicating or conflicting treatments, and they can bring that with them anytime that they have an appointment. So that binder could contain a face sheet, some health monitoring calendars, a medication list, a medical history list, any educational materials that they've been given, lab test results and appointments, physician's contact information, as well as a question section. This can also be an electronic form. It doesn't have to be a handheld. It's what the patient prefers. If the follow-up visit is a telephone visit, which is an option, it is important to document this encounter to ensure that the patient is meeting their goals. The medical director needs to establish perimeters or guidelines of any phone visits that you end up using within this perimeter. Unscheduled home visits. So these occur when a patient has called 911 or the agency's non-emergency line requesting assistance or help. It's important to understand local ordinance or what your state laws are regarding a patient calling 911. The medical director must establish a response protocol to ensure no laws or statutes are being violated. So that's going to be Dr. Lacey in Henderson County, Dr. Hareen in Buncombe County. If a community paramedic responds in lieu of an emergency medical services response unit, then this has to be prior established and prior built. Okay. End of care visits. So this is when you are at the end of the program. So the final visits that you will have with your patient. That is dependent on the patient meeting the goals of the plan of care. Ensure that the patient does understand how future communication should occur moving forward. During that end of care visit, the community paramedic may cover the following bases per local protocols: repeat or evaluate the patient needs assessment and medication inventory, evaluate the patient's understanding of his or her medical conditions, ensure that an ongoing communication process has been established between the patient and their provider. Identify any remaining barriers that they may have. So helping them figure out barriers that they may still need to jump over helps ensure success and keeps them moving in the right direction. Ensure an appropriate transfer care to a necessary entity as well. And always congratulate the patient on their success. Leave them with a positive experience. Then we move on to disenrollment visits. So this is a visit in which community paramedics must end the program due to patients' continued refusal to follow the plan of care. It is important to develop a generalized guideline for the community paramedicine program to follow when this does happen. That way you are handling each person the exact same way. During the disenrollment visit, a full patient assessment may be performed, and this can include identifying and documenting which specific guidelines, policies, or medical advice the patient is not adhering to, how long this behavior has occurred, any patient's barriers to success, which might include the patient's own perception, patient's psychological condition. We want to ensure that the patient or another competent adult or medical director fully understands the implication of the non-adherence and the disenrollment from the program. Depending on the community paramedicine program, the patient may sign a refusal or declination of care form if possible. This form may contain warnings such as formal against medical advice, acknowledgement, much like those found on our EMS refusal care forms. Precise format is going to differ for each program, and it's going to depend on local, regional, and state protocols and laws. Education, patient education. So you guys are well positioned to deliver customized education as part of their focus on truly patient-centered outcomes. So because community paramedics can take time to listen to our patients, we also have the unique opportunity to identify barriers or gaps in knowledge for each patient. So it is important for us to understand how adult learning takes place, determine the patient's educational level, determine how to communicate effectively with each patient based on their individual needs. So for example, patients with congestive heart failure often say they do not add salt to their meals because of the sodium restrictions they have. We have the luxury of spending more time with patients so they can review the actual sodium content and various types of foods that patients eat daily. I always start out educating and talking to someone like they're a fifth grader, and then evaluate and change as you go. There are different learning styles, three main types in particular. So we've got visual. Our visual learners must be able to see what is being presented and retain written information. Auditory, so these are learners who prefer to hear the information, which is one of the reasons why I am recording these for you, and are better able to retain information when it is presented this way. Our kinesthetic learners must be able to take the information and physically apply it to help retain the information. I find this is common with most of our EMS students. So learning by demonstrating a skill makes it stick. So when educating a patient, it is critical to discuss, write, and help patients apply the knowledge that they are being given. So whatever works best for that patient. Some patients may have had to learn new styles, such as visual learners who have lost their eyesight. So during our intake visit, ask the patient how they prefer to learn. And then we'll need to tailor the education to that patient's preferred learning style. So an example, so after demonstrating how to use a glucometer, ask the patient to practice measuring their own blood glucose while you observe what they do. Health literacy. So this is the ability to gather or otherwise obtain basic health information, how they comprehend that information, and then how they make appropriate health decisions based on that information. Some people have low health literacy and is known to produce poor outcomes in healthcare. Patients must be able to comprehend the health-related information provided to them if they're going to accomplish self-efficiency, self-regulation. So our roles are to understand each patient's health literacy level and customize the education provided to that person's need. They actually recommend here that you start at a third grade level and add more complexity if needed. So that is also something that is recommended by this curriculum. Keep in mind, keep it simple. If your patient has a very specific and limited ability to learn, you will need to ask the patient what level of education they have achieved. Ask whether they have any specialized learning conditions. Are they dyslexic? Things like that. Alternatively, ask the patients if they understand or can read back some of the instructions to you. Establishing, once again, that good rapport is so key to encouraging open discussion of these issues with your patients. On to educating patients with chronic condition. All education for patients with chronic conditions should emphasize 6 key steps to management. Go to your doctor. Take medication as prescribed. Monitor your symptoms daily. Maintain a balanced diet for your conditions. Stay active and exercise as directed. Limit or avoid use of our harmful substances known as drugs, nicotine, and caffeine. Help our patients with chronic diseases understand that medicine does not fix the medical condition, but it helps them manage the condition. You know, those patients that we show up and ask them what is their medical history, and they say they don't have any medical history, and then they hand you about 15 prescriptions, and they say they don't have a medical history because their medications have taken care of those problems. So we also want to confirm the patient's understanding before ending the educational component. Have the patient teach you that information back. Ask the patient what he or she understands about the disease that they have. Also ask them how this changes their daily routine. Revisit questions to assess the patient's progress. Also encourage patients to write down questions to ask their provider during future visits. They may be open and communicating with you, but by the time it comes around to their appointment, it may go out the window. Patients should write down the provider's answers as well, and that way the community paramedic can also assess the understanding of those responses too. So the selection of educational tools are needed for each of the specific diseases that the community paramedic will be monitoring and managing in each patient. If there's an educational program that you would like to present, you're going to need to get the appropriate approval to reprint the material. You also want to ensure your medical director approves of the educational material. Some hospitals may create their own educational pieces and classes, which then may be reviewed and approved by the medical director. If the community paramedic attends these classes, he or she should be prepared to customize the education to each patient's needs as well. Interacting with payers. So payers, what are the payers? Your payer is a source of reimbursement funding for services provided to a patient by a healthcare provider. Payers can be divided into 2 groups. You've got your government payers, that's your Medicaid or Medicare, and then you've got your private payers. Our Medicare is a federal program that provides health care insurance for adults over 65 or adults and children with disabilities, no matter what their income. Medicaid is a joint state and federal program that provides health care insurance to adults and families with low incomes. Within Medicare and Medicaid, there are two types of patients. There is a fee-for-service patient. These are patients who find a provider willing to accept Medicare or Medicaid, and those whose services are billed directly to Medicare and Medicaid. Managed care patients are patients whose care is paid through a plan and managed by a private organization. So could be HMOs for Medicaid and Medicare. Private insurance companies can be organized into a variety of ways to provide health insurance for patients. Exclusive provider organizations, or EPO. A managed care plan where services are covered only when they are delivered by the plan's physician, specialist, or hospitals. An exception is made in emergencies always, though. Health maintenance organizations, as HMOs, a health insurance plan that may require patients to live or work in its service area. This plan usually limits coverage to care from physicians who work or contract with that HMO. There's also a point of service plan, POS, a health plan in which patients pay less if they use providers in the plan's network. Patients can access providers and hospitals outside this network, but at an additional cost. There's a preferred provider organization, PPO, a plan that allows patients to access providers and hospitals outside of its network without a referral, but at an additional cost. And the Patient Protection and Affordable Care Act, PPACA, which requires that people in the United States be covered by a policy that complies with the regulations set forth in this act. For community paramedicine programs to survive, for these programs, they must have some form of sustainable funding. So for you all, that may be grant funding. That may be why you were able to kick off this program. So initial funding can be community, state, or those federal grants. More sustainable funding could come from a hospital, healthcare organization, individual EMS agencies. Medicare and Medicaid HMOs, along with private insurance companies, are beginning to reach out to EMS agencies to develop community paramedic programs. Community paramedics can help reduce emergency department visits and improve payers' bottom lines through monitoring, managing, and educating patients with chronic diseases. So it is starting to see, or they are starting to see, that this is necessary for us within our communities, which is why that funding is coming out more and more. In recent years, healthcare in the United States has begun moving towards a patient-centered healthcare model, which involves patients and their families in the design of the new care models, the decision-making about individual options for treatment, and that is exciting progress. As community paramedicine programs search for sources of sustainable funding, they will need to meet the goals of the Institute for Healthcare Improvements. Our triple aim to qualify for such funding. The triple aim is a threefold approach designed to help optimize healthcare delivery by reducing healthcare cost, improving the health of the public, optimizing the patient's healthcare experience. Some of these changes to the payer system include creating organizations that better match the Centers for Medicaid and Medicare Services. These transitions from fee for service to other forms of payment, such as value-based payments, reimbursement strategies used by payers to promote the quality and value of healthcare services. For example, through pay-for-performance programs that reward improvements in quality metrics. Bundled payments, reimbursement strategy in which payers provide a single payment for all services delivered. Shared risk payments, a total cost of care payment. This model is aimed at reducing overall expenditures for an episode of care. Accountable care organizations, or ACOs, are being formed to ensure that providers are meeting the goals of the triple aim by controlling payments. ACOs are groups of physicians, hospitals, and other healthcare providers who provide coordinated healthcare to Medicaid-covered patients. The goal of coordinated care is to avoid duplication of care, reduce the potential for medical errors, help patients receive the correct level of care, at the correct time. Payer communication. With the implementation of the Triple Aim, community paramedicine programs will need to demonstrate that they are meeting the goals of the Triple Aim to receive that payment. Each payer will require specific information and data collection, and this will be mandatory. In 1994, the National EMS Information System was created to link EMS databases across the United States so that information can be shared. The most recent version of this data set is composed of 3 separate components: a demographic data set, an EMS data set, and a format and definition created to promote sharing of data elements between data systems. The sharing of our NIMSIS data has the following benefits. We have improved analysis of EMS procedures and patient care, comparison of data across jurisdictional and state boundaries, better evaluation of the EMS role in healthcare. In 2017, the standard collection of patient data from EMS systems will change as a transition is made from NIMSIS 2 to NIMSIS 3. NIMSIS 3 is designed to quickly monitor health issues that arise in specific local areas, monitor the EMS healthcare providers, including community paramedic programs. Each community paramedic program will also need to demonstrate the level of performance of its community paramedics through a set of key performance measures. The EMS Compass project is currently developing these measures to help EMS systems improve the quality of care they deliver. Paperwork will be mandatory for any healthcare provider who wants to be reimbursed for services, and those are testables, just letting you know. Documenting patient information for a payer. Documenting and collecting data differ for the paramedic versus the community paramedic. To document a non-emergency visit, the community paramedic will use a form created by the department or by one of the electronic patient care record EPCR vendors. This form will capture the specifics of the visit, including a prescription inventory or taking of vital signs, among other requirements that have been set forth. By sharing this kind of data with hospital and the payer, the community paramedicine program can ensure that they will understand that the care provided by the community paramedic is saving the payer money and keeping the payer out of the hospital. Currently, there are no standard billing forms that each payer uses across the U.S. Although each payer may require a different type of form to be completed, in most cases that information stays the same. Each community paramedicine program will have protocols and procedures on how patient information is to be collected and documented for both payers and healthcare providers. The medical director will determine how patient information is collected and documented for each community paramedicine program. Full documentation of each encounter is vital to ensure the continuity of our patient care, demonstrate to the payers that the community paramedic is meeting the requirements of the Triple Aim. Documentation. Our community paramedics face challenges beyond caring for the patient's specific medical condition, such as meeting the goals of the Triple Aim. This could mean meeting healthcare needs that are more social in nature than medical. Sharing patient information outside of healthcare systems can prove challenging for these programs. So owing to the Health Insurance Portability and Accountability Act, so HIPAA does pose a problem. Community paramedics must understand HIPAA and conform to its rules. What is said to neighbors, which resources are consulted to solicit social aid, that's churches, senior organizations, and such. Which resources are assessed to meet basic needs, such as food banks, Meals on Wheels. HIPAA allows the exchange of SOAM data with parties outside of the traditional healthcare organization in an effort to meet the explicit healthcare needs of the patient. The allowable data that can be exchanged must be approved by the organization's HIPAA compliance officer. So for our last slide, each community paramedicine program will determine the types of checklist form that the community paramedic will use to document the patient visit. Your agency should have this pre-planned and ready to go. Special requirements for data collection may be established for community paramedics by their program's medical director. The community paramedic must document all of the care provided for the patient's medical and social needs. Examples may be finding ways for the patient to get to the primary care physician. The same level of documentation that is required in the hospital or physician's office will be required of the community paramedics working in the field. Community paramedics will meet the highest performance standards and provide cost-effective care. So in a nutshell, that is interactions that you will have with our different parties within the community health program. Once again, thanks for listening. Stay safe.